Good evening, everybody. Welcome to our Young Leader Forum webinar. A Young Leader Forum webinar is an activity that is by the Emirates Diabetes and Endocrine Society. Our theme for tonight is Pituitary Care. It will be presented by 4 distinguished speakers and we'll be having in between our Q&A session. For tonight, our academic activity is supported by Servier. For the attendees, just to know that our webinar is CME accredited by Dubai Health Authority. Following the webinar, you will be receiving a survey. Kindly fill the survey, and within 10 to 14 days, you should be receiving your credits. Our webinar for tonight, you can watch it again on YouTube channel, EDES YouTube channel, as well as you can see it on the EDES Institute site on demand for tonight. For any queries, you have our live chat support. For any technical issues, you can contact our WhatsApp number. And without any further delay, I'll be starting with the first presenter. The first presenter, Dr. Noura, will give us a talk on approach to growth hormone deficiency during the transition period. Dr. Noura Al-Hassani is the Chief of Pediatric and Endocrine Diabetes Division at Tawam Hospital. She's as well Adjunct Assistant Professor at College of Medicine and Health Science at UA University in Al Ain. Dr. Noura has an research interest in type 1 diabetes and a growth disorder. So I'll hand the mic to Dr. Noura.
Thank you, Bidur, for your kind introduction. I hope you can see my slides well. It's my pleasure to participate again in the Younger Leader Forum. My talk today is going to be about approach to growth hormone deficiency during a transition period. So what we will do here is we will go over the patient journey who has been diagnosed as growth hormone deficiency from the pediatric age till he go into adulthood, passing through what we call a transition period. So our objectives here during the childhood will cover the growth hormone deficiency, growth hormone treatment, the transition period definition, approach, growth hormone retesting, and finally the adulthood growth hormone treatment and monitoring. To go to basic, growth hormone IGF-1 axis and action. Growth hormone is being secreted, as everybody know, as a pulsatile secretion from the anterior pituitary gland under a positive control of growth hormone releasing hormone and negative control from somatostatin, both secreted from hypothalamus. The main target of growth hormone is the liver, through which it secretes the IGF-1. But as well, it has a direct effect in the bone, where it can secrete a local IGF-1 in the growth plates itself. IGF-1, then it binds to the IGF binding protein, 3, 4, and 5 has been stimulated by growth hormone as well. And it will form an inactive complex released into the circulation. The free IGF-1 is which goes to the peripheral tissues and bind to the receptor, results in its main effects. So growth hormone effects is known to be stimulation of linear growth. It also can cause lipolysis, stimulation of protein synthesis, hyperglycemia, improving bone mineralization and bone density, reduction fat mass, improved lean body mass, and altered insulin sensitivity. So again, going back to the patient journey, it all starts with the first pediatric care. So it is the time when the patient himself presents, how he is presenting, how the diagnosis of growth hormone deficiency should be done, growth hormone started, and maybe as well a time of stopping the growth hormone, or could be this, or this could be done in the second transition phase. So growth hormone deficiency in children, in general, it has an incidence of ranging from 1 in 3,480 up to 1 in 10,000 in US and in Europe. causes of the growth hormone deficiency could be either congenital or acquired. Congenital causes include genetics, so any mutations involving transcription factor defects can result in growth hormone deficiency, whether it's been isolated or associated with other pituitary hormones, as well as if there's any mutations in growth hormone releasing hormone receptor genes. Could be associated with a brain structural defects, such, for example, agenesis corpus callosum, septo-optic dysplasia, empty cella syndrome, holobroncephaly, encephalocele, hydrocephalus, and arachnoid cyst. And finally, could be associated with a midline facial defects, such as single central incisor or cleft lip palate. On the other hand, acquired causes could be due to trauma, perinatally or postnatally, CNS infections, tumors, such mostly craniopharyngioma, infiltrative or granulomatous disease, tuberculosis, hypophysitis, could be cranial irradiation, surgery, pituitary or hypothalamus, infractions, or finally idiopathic. Most common cause in children, at the age of childhood, mostly it is a growth hormone deficiency is due to the idiopathic growth hormone deficiency. So how such patients they are present? There's variation in presentation, definitely based on the age and based on the severity or degree of the deficiency. So in a neonate, you might see hypoglycemia, prolonged jaundice, microcephalus, and or cryptorchidism in males, while in the pre-pubertal children, most common presentation, and it is the most common complaint in our presenting to our clinic, is the short stature, reduced growth velocity, as you can see in the growth chart. In cases of severe growth hormone deficiency, they might present with specific features, such as immature faces, prominent forehead, depressed midline development, single central incisor, optic nerve hypoplasia, thin sparse hair, as you can see, slow nail growth, high-pitched voice, low muscle bulk, increased subgut fat, and LDL cholesterol. So how diagnosis of a growth hormone deficiency done? First of all, definitely you need the clinical and psychological assessment. Very important to go back to the history, physical exam, taking more details about your birth history, any trauma, any congenital defects, any medications, radiations, any chronic illness, in addition, definitely to any associated symptoms. Psychological assessment, very important to take the height and plot it in the chart and assess how is the growth velocity itself. So in general, it is worth definitely evaluate growth hormone deficiency, specifically for those who have a short stature of less than minus 3 SDS below the mean, or the height less than minus 1.5 below the mid-parental height, or the height less than minus 2 below the mean, and either growth velocity less than minus 1 below the mean over the past year, or decrease the height itself SDS more than 0.5 over the past year. In absence of a short stature, growth velocity itself, it's been dropping less than 2 standard deviation below the mean over 1 year, or below minus 1.5 below the mean over 2 years. Signs of intracranial lesions, signs combined pituitary hormone deficiency, and finally neonatal sign and symptoms of growth hormone deficiency, which is mostly hypoglycemia. So beside this, the clinical, there is definitely the biochemical test which help or confirm even the diagnosis. Related to growth hormone itself, definitely IGF-1 and IGF binding protein, but not please random growth hormone. Do not do a random growth hormone level, because it is a pulsatile secreted, as we said, and it is not really helpful in the assessment. The other point in test is the growth hormone stimulation test, which is, despite being not everybody agree on the stimulation, as it is known to have more lack of reproducibility, accuracy, different cutoff levels, different immunoassays. However, still the growth hormone stimulation test considered to be the gold standard in diagnosis of growth hormone deficiency. And based on the Pediatric Endocrine Society, they do recommend to use 2 stimulus in pediatric, as well as it is recommended to do a priming for those pre-pubertal boys more than 11 and girls more than 10 years. There are definitely a stimulus to be used. For example, in our center, we are using a glucagon and a clonidine. Other criteria beside the clinical and biochemical, there is the radiological evaluation. So bone age, X-ray usually is being, or typically it is delayed in such patient. MRI pituitary is very important to check if there is any structural defect or mass or whatever a reason behind growth hormone deficiency. And at the end, there is the genetic test, which is again based on the clinical scenario. Not all patients growth hormone deficient or short stature, you go directly with genetic. So what is the management in such patient? It is definitely the growth hormone therapy. The main goal of therapy in pediatrics is to improve the linear growth. So it will accelerate the growth in early childhood as much as possible to achieve rapid catch-up growth, to maintain normal growth later in childhood. And at the end, it will normalize the adult height within the genetic target range. Besides, definitely restore the normal physiological equilibrium. So growth hormone use has been there since many years, exactly 1958, with the use of pituitary-derived growth hormone for first case adolescent patient. Then it was followed with the use of many of pediatric and adult patients. Till 1985, when the era of recombined human growth hormone has been started, and it has been approved for growth hormone deficiency. Later on, it was followed by other indications, has been approved by FDA and by EMA for many of non-growth hormone deficiency. Growth hormone deficiency has been proved to be beneficial in many studies. One of them is a large international database from the KIGS where they looked at 1,258 patients with growth hormone deficiency. 980 were Caucasian and 278 were Japanese. 747 were isolated growth hormone deficiency, while 511 was with multiple pituitary hormonal deficiency. So what they found that those patients in the near adult height, SDS, it shows a significant improvement, reaching -0.8, -1 in male and female, as well as in the isolated growth hormone deficiency, as well as -0.7, -1.1 in the multiple pituitary hormonal deficiency group. The same in the other group of Japanese, the isolated and multiple pituitary hormones showed a significant improvement on the final or near adult height. They found that the difference between the near adult height and the mid-parental height, yes, it ranging between -0.6 and 0.2 SDS for the Pharisee groups, and they did conclude that it is possible to achieve a final height within the mid-parental height range in patients with isolated growth hormone deficiency treated from an early age with growth hormone, but absolute height outcomes, it remains in the lower part of the normal range. With patients associated with multiple pituitary hormonal disease, in general, has a slightly better long-term height outcome. In general speaking, you need to know that there are many factors can predict the response, the growth hormone response. One of them is the diagnosis itself. In cases of growth hormone deficiency, the severity of deficiency, age of the patient, the younger patient, the better outcome, the parent's height, growth hormone dose, and finally, the growth response in the first year of therapy. So for how long you keep the patient? So once you diagnose the patient with growth hormone deficiency and you started him on growth hormone, you keep the treatment, and usually it is a long-term treatment till you reach what we call it a near adult height, where the growth velocity is start to drop less than 2 cm, reaching less than 2 cm per year, and bone age around 16 in boys, 14 years in girls. At this point, you have to, or you need to close or stop the growth hormone treatment. And at this point, probably you will the patient will move into the second phase, which is called the transition care. Transition care is a critical phase in between the pediatric and adulthood. It needs more of different modalities, more personnel, pediatric, adult endocrinologist involvement, more of educational skills, more involvement of the family and or the patient himself. So during this phase, you need to go back and see what is your patient has exactly, what is his original cause of his growth hormone deficiency. You need to decide if he needs to be retested, if yes or no, is there a need to resume growth hormone treatment or keep it off. Before we proceed, let's take your opinion in your own centers. At what age the pediatric patients being shifted to adult service? In other words, what is the pediatric or the age cutoff level to move pediatric to adult? You have 15 seconds here to answer, and definitely there is no right or wrong answer, just to take your opinion. Here we go. So you have 15 seconds. Okay, so we are done. Here it is 31%, 15 years, 28, 12 years, 22, 16 years, 19%, 18 years. So definitely this is show how it is really, it's not all the same. It depends on the center, your own practice, your own culture. So there is no clear cut-off level of the age to move the patient into adult service. However, this is not the transition. We are not talking in transition. It is not really the cut level of the age itself when to move to the adult. Our transition phase is actually more of a period where there is more of physiological changes, usually period at end of the puberty, till achieve a full adult phenotype with maximum bone mass and muscle strength. In many resources, it has been estimated to be from the mid or to late teens until 6 to 7 years after achieving the adult height. So why this transition is important? For two main reasons. The first one is they found that 20 to 87% of children diagnosed with growth hormone deficiency, when they retested at the end of the stature, reaching stature growth has been, it was found to be more of a normal growth hormone secretion. And this, the subjects with idiopathic isolated growth hormone found to show more or higher percentage of normal growth hormone post retesting. Why is this? There are multiple reasons. One of them could be simply because what the patient has was more of a transit partial growth hormone deficiency, not a complete one. Could be because of recovery or improving of hypothalamic pituitary function after puberty. Could be related or mostly related to the growth stimulation test itself, with changing the diagnostic criteria, changing the response to a different stimulus. For example, even false positive results in patients of delayed puberty. So this is an example of one of the studies done for patients, 38 children with idiopathic isolated growth hormone deficiency who was still on growth hormone treatment. The initial diagnosis was based on subnormal growth hormone response to a two stimulus stimulation test and a normal brain imaging or minor or non-specific findings at MRI. They found here that almost 95%, 36 out of 38, growth hormone secretion was normal. Two of them, the rest, the two were slightly reduced peak growth hormone responses and had a normal IGF-1 levels. That's why among the causes of growth hormone deficiency in adults, definitely there is what we call the childhood onset growth hormone deficiency, beside the other acquired causes, the tumors, brain injury, autoimmune, infiltrative or empty cell syndrome, or idiopathic. In general speaking, most common cause of growth hormone deficiency in adults is due to pituitary adenoma. However, what do you think? How much the percentage of the childhood onset growth hormone deficiency is among all the total adult growth hormone deficiency cases? You have 15 seconds to answer. So the answers here are mostly 47% are saying 15 to 20%, 30%, 50%, and 21% is less than 10%. The right answer is 15 to 20%. So 15 to 20% of all other cases are secondary to the childhood onset growth hormone deficiency. That's why very important to know specifically those patients who continue into adulthood with the growth hormone deficiency condition. The other reason of importance transition is that patient, yes, has been completed the linear growth. However, still the growth hormone dependent somatic growth still continue, and it continue years till adulthood and beyond adulthood. So growth hormone has been known to be important metabolic actions throughout the adulthood. There's effects on the bone and lipid metabolism, body composition, quality of life. That's why clinically patients or adults with growth hormone deficiency, they do present with increased fat mass, decreased lean body mass, decreased muscle strength, decreased exercise performance, decreasing cardiac capacity, decrease the bone mineral density, and increasing risk of fractures, abnormal lipids, thin dry skin, psychosocial issues with quality, decreasing quality of life, fatigue, depression, and anxiety, impaired sleep, and social isolation. Not all studies, but I will say most of the studies show that interruption of a growth hormone replacement in adolescents with severe growth hormone deficiency, it leads to an increased cardiovascular risk factors, such an increase in the visceral obesity, decreased in the lean body mass, increase in the total cholesterol, LDL, apolipoprotein B, and decrease in HDL. Body fat increases progressively as well with halt or decline in the accurate lean body mass. And finally, there is a limit on the optimal peak bone mass in adolescent. This is just to show you as well an example of the complications of such patients. So this is a study done by Carol, has been published in 2004, where they looked at and compared those patients who continue on growth hormone with those who stop growth hormone once they complete the linear growth. And their main aim or objective was to look at the body composition and metabolic status. So they include a 24 adolescent, 13 male, 11 females, with age of 17 plus minus 0.3 years, reaching end of a puberty and reaching growth velocity of less than 2 cm per year. Provocative test is done on confirming a severe growth hormone deficiency in all of the cases. Baseline investigations done after follow those patients after 3 months. Then 12 patients remained in the growth hormone, and another 12 stopped the growth hormone. Then again, they repeat all those investigations again at 6 months and again at 12 months. They found that A growth hormone cessation results in reduced or reduction of the serum IGF-1 Z score baseline compared with 6 and 12 months, but the values remained unchanged on those who continue treatment. They showed an increase in insulin sensitivity as well, again, comparing basal with the 6 and 12 months. But there was no significant change seen during 12 months of growth hormone continuation. Here, the lean body mass was increased by around 6% over 12 months in those receiving growth hormone, but was unchanged after growth hormone discontinuation, and the lipid levels remained unaltered in both groups. Another study done to compare or to look actually for those growth hormone replacement and growth hormone deficient patients during that transition over a 2 years placebo-controlled study. And here they include 19 young adults, 13 males with and 6 female. Age was mean of 20 plus minus 0.6, all with a childhood onset growth hormone deficiency. It was more of a randomized, parallel, double-blinded, placebo-controlled trial for 1 year, then followed by an open phase with the growth hormone for 1 year. So all patients was receiving growth hormone in the beginning, then a trial medication with a growth hormone or a placebo was given at a similar dose and been followed for a year. Then those group with the placebo had been resumed on a growth hormone for another year. They found that patient randomized to continue growth hormone showed no significant changes in any parameters tested, but the inter-individual variations in the IGF-1 level itself were suggesting more of a compliance problems. While in those who did discontinue growth hormone for a full year, showed decrease significantly on the serum IGF-1, increase in the total body fat as well. On the other hand, restarting growth hormone after the placebo showed an increments on the IGF-1 level and IGF binding protein 3. Increments on the fasting glucose, lean body mass has been increased as well, and finally increasing the thigh muscle volume and thigh muscle fat ratio. So now, regarding re-evaluation, growth hormone and IGF-1 axis in the transition phase, how we do it, when, who, and how to retest. So to start with, when, we agreed whenever growth hormone has been stopped on reaching the final adult height, in general speaking. Who should be retested? This is based on the American Association of Clinical Endocrinologists and the Endocrine Society. They were recommending once growth hormone has been reached the final or near adult height, or growth velocity is dropping less than 2 and bone age 16, as we said, or 14, 15 in girls, to stop growth hormone and reassess IGF-1 after at least 1 month, 1 to 3 months. So in cases, patients with already a genetic mutations or congenital malformations or organic defects with more than or equal at least 3 pituitary hormonal deficiency plus low IGF-1, in this group, there is no need for retesting, no need to do a growth hormone stimulation test, and you need to resume growth hormone treatment directly. In some resources as well say, they are saying even the genetic and the congenital structural defects, such as septo-optic dysplasia, for example, no need even to interrupt the treatment and to repeat IGF-1. Directly, you can resume the treatment. Probably those with organic, more than 3, they will require as well a low IGF-1 to decide on no retesting. On the other hand, the other organic causes, for example, craniopharyngioma or so, with less than 3 pituitary hormonal deficiency, none, 1, or 2, and IGF-1 found to be low, then this group will need to be retested and accordingly to restart the growth hormone treatment if needed. Finally, the idiopathic or the isolated growth hormone deficiency will need to do an IGF-1 definitely here. So if it is low, then yes, it has high probability of persistent growth hormone deficiency, and you need to do the retesting. While if it is with the normal IGF-1, then no need for retesting and no need to resume the growth hormone treatment. The last one, how to do the retesting. Definitely in adult, the same. They are using a growth hormone stimulation test. There are different tests to be used. Insulin-induced hypoglycemia is considered still the gold standard test. However, and with definitely less cutoff level, 5 nanogram per ml. However, it has side effects, significant hypoglycemia. It is contraindicated in elderly, contraindicated on epilepsy or seizures, and cardiac or cerebral vascular disorders. That's why alternative to the test could be used the glucagon stimulation test. Other forms as well is there, but again, each has its own side effects, availability, different cost. If you notice the difference between the stimulation test here between adults and pediatric, mostly, first of all, the cutoff levels. So they are using much less cutoff level than in pediatrics. Second thing is the BMI adjusted cutoff levels, which is not there in pediatric. So if you decide the patient after doing growth hormone stimulation test, you decide that this patient is in need to restart him on growth hormone treatment. So the question here is how much or how the dose will be. So for those who has been just shifted from the pediatric, usually they are requiring higher dose. So some resources suggest to start 50% of the previous dose, and then continue to adjust the dose gradually, making sure clinically there is no symptoms. At the same time, the IGF-1 is within at least mid-normal. You reduce the dose in general to reach a higher dose, 0.2 to 0.3 milligram per day in younger age, and on those with oral, female with oral estrogen, while a less dose in older age. Definitely increase or decrease the dose based on the patient's clinical conditions, lab, IGF-1, and other features. Regarding one point of IGF-1 level, you need to keep in your mind a low level could be there anyway, and if the patient has a malnutrition, malabsorption, chronic liver disease, renal failure or disease, uncontrolled diabetes, severe illness, severe trauma, including surgical trauma. The final step or the phase is the adult care, where you are the patient continue with the adult endocrinologist, where the patient need to keep on growth hormone replacement. You need to ensure the compliance, which probably should become better with approved once weekly growth hormone last year. You need to monitor the patient closely for IGF-1 and for any side effects. Regular monitoring has been suggested to be every 6 to 12 months of body composition, BMI, waist circumstance, cardiovascular, blood pressure, pulse rate. Need to do DEXA scan from every 2 to 5 years according to the condition. Every 6 to 12 months fasting lipids, fasting glucose, hemoglobin A1C. Again, assess quality of life at least once a year. Assess for any side effect. Later on, patients, especially with those any post-surgical tumor remnant, need periodic MRI before and annually later on to assess any progress. Again, serum IGF monitoring is needed, and don't forget to assess and manage the other pituitary hormonal deficiency. So our take-home message here, in cases of a growth hormone deficiency, in children, the primary goal of recombined growth hormone therapy is the growth promotion to normalize final adult height, while in adult patients, the main goal of treatment is to reverse the adverse metabolic consequence of hormone deficiency and improve quality of life. proper assessment of a childhood onset growth hormone deficiency patients during a transition is critical to decide who may benefit from continued growth hormone treatment. Thank you very much for your attendance. And the mic back to you, Bidur. Thank you.
Thank you very much, Noura, for the presentation. Very comprehensive and thorough. Okay, so we move on with the second presenter. Dr. Rai will be presenting approach to a case with polyuria and polydipsia. Dr. Rai Al-Mazroui is a consultant endocrine at Tawam Hospital. She finished her fellowship training in diabetes and endocrine at Imperial College in London in UK. And she's also a graduate of Harvard Medical School Global Clinical Scholars Research Training. She's heavily involved in academic teaching for both under and post graduates. So the mic is yours, Dr. Raya.
Thanks for giving me the opportunity to present today. I'm going to present about the approach to case with polyuria and polydipsia. The objectives for today's presentation includes definition of polyuria and polydipsia syndrome, the different etiology of polyuria polydipsia, diagnostic approach, and a new diagnostic test for differential diagnosis, and then we'll go over the treatment options and its principles. What will not be covered in this presentation today is the post-surgical or post-traumatic DI and adipsic DI. And I recommend for those who are interested to read more about this topic for this freely available review by our colleagues from the Gulf, which is open access and available online. First, to start with anatomy. AFP, or vasopressin hormone, is synthesized in the supraoptic nucleus and paraventricular nucleus in the hypothalamus. And then it is transported down the axons of the pituitary stack and released from the neuron terminals in the posterior pituitary based on the stimuli. Now, both increased plasma osmolality and decreased blood volume stimulate AFP secretion, but with different thresholds and sensitivities, as depicted in the graph. When we define polyuria polydipsia syndrome, the three conditions has to be satisfied. First, hypotonic polyuria, which means polyuria more than 50 ml per body weight within 24 hours. Accompanied by polydipsia, which is excessive drinking with around 3 liters per day, and exclusion of other disorders that cause osmotic diuresis, like uncontrolled diabetes. The most common causes of polyuria polydipsia syndrome include central diabetes insipidus because of destruction of a neurohypophyseal neurons or mutation in AFP, or primary polydipsia due to excessive fluid intake. Both will lead to decrease in pituitary AFP release. Nephrogenic diabetes insipidus is due to decreased response to AFP or mutation in AFP receptor 2 or aquaporin 2. And this will lead to the renal resistance to the serum AFP. Another form of diabetes insipidus manifests during pregnancy called gestational diabetes insipidus. And this is usually at the end of the second trimester, early third trimester, with the peak of vasopressinase production from the placenta. And this is basically leads to the excessive destruction of the AFP by the vasopressinase produced by the placenta. The direct result of all these leads to the decreased free water reabsorption and increased solute free water diuresis. Now, there are several causes for polyuria polydipsia syndrome according to the basic defect. However, the most common causes are acquired causes. For example, in case of central diabetes insipidus, the most common causes are trauma-related, neoplasia-related like craniopharyngioma or meningioma, vascular events, or granulomatous disease like histiocytosis and sarcoidosis, or infectious reasons like meningitis and encephalitis, or inflammatory and autoimmune conditions leading to hypophysitis and drug or toxin exposures. Other hereditary causes including AFP mutation. Nephrogenic diabetes insipidus, mainly due to drugs like lithium, nucleocycline, and cisplatin, or metabolic condition like hypercalcemia or hypokalemia, or infiltrating lesions like sarcoidosis and amyloidosis, or vascular disorder like sickle cell anemia. Other hereditary causes, including AFP receptor 2 mutation or aquaporin 2 mutation. A primary polydipsia due to excessive water intake due to psychogenic causes or compulsive water drinking. And as I said, gestational diabetes, which is usually manifest during pregnancy. Now, usually the aim when we speak about polyuria, polydipsia syndrome is really to differentiate between these two conditions, diabetes insipidus and the primary polydipsia. However, before we go through the ways how to differentiate between these two, there are certain points we need to be aware of. First of all, diabetes insipidus is a rare disease. Its prevalence is around 1 in 25,000, while polyuria, polydipsia are very common. Number two, the reason to differentiate because the treatment differs across etiology, and we need to prescribe the right treatment for the right diagnosis in order to avoid complications. And in many times, a clear history and basal testing are enough to differentiate. However, sometimes you will need a stimulated test. So let's move to the diagnosis. There are 3 tools that can help us to diagnose or to differentiate among the 2 main types of polyuria polydipsia syndrome: a clinical presentation, basal testing, and stimulation test. Let's start with the first case. This is a 43-year-old female who was referred with a 6-month history of polydipsia, according to her, started all of a sudden. But no polyuria, no headache, and she has a regular period, no weight loss. And rest of system review was unremarkable, including dermatological and rheumatological systems. She has history of use of over-the-counter supplement for weight loss prior to the symptoms onset. She has insignificant past medical history or past surgical history. Her initial random labs done by the GP showed low normal sodium, normal potassium, normal calcium, and normal hemoglobin A1C. Her serum osmolarity was within normal range, and urine osmolarity was low. Therefore, basically, she was referred to rule out diabetes insipidus. Let's talk first about the clinical presentation. The clinical presentation in these cases depends on the thirst perception. If it is impaired, then the manifestation with dehydration and hyperosmolarity can occur if water loss cannot be compensated by fluid intake. And therefore, manifestation may range from non-specific symptoms such as irritability or cognitive dysfunction to more severe ones like disorientation, reduced consciousness, seizure, or coma. While inpatient with intact thirst perception can give you a more detailed history. Now, classically, it has been known that central diabetes insipidus had some certain characteristics, including nocturia, sudden onset of symptoms versus long-standing symptoms in nephrogenic diabetes insipidus and primary polydipsia. And it have a more sustained and less fluctuating course of symptoms. And the reason behind that is that the ability of the urinary concentration can be maintained until the residual capacity of the hypothalamus to synthesize AFP falls below 10 to 15% of normal, after which urine output increases significantly. Also, historically, it has been reported that patients with DI, in contrast to the primary polydipsia, preferred cold water. However, this does not stand true all the time. And this was one of the first studies prospectively evaluated the symptoms of patients with central diabetes insipidus and primary polydipsia. And you can see that there is a huge overlap between symptoms in these 2 conditions. So even patients with primary polydipsia can report nocturia, drinking at night, or preference to cold water, or sudden onset of symptoms, or persistent symptoms. So sometimes these symptoms may not differentiate between these 2 conditions. However, sometimes also we need to take very clear history. You need to ask the patient whether they really having thirsty, or they are suffering from mouth dryness, whether they really have polyuria or it is a frequency. And sometimes you need to do a 24-hour collection in order to document the polyuria. And you need to ask about nocturia and drinking at night. And also, we have the luxury here to ask about the ability to fast Ramadan. Also, during history, apart from asking about symptoms to differentiate between the different types of polyuria, polydipsia syndrome, you need to look for etiology. And therefore, you may ask about symptoms such as headache, visual symptoms, or B symptoms, ask about the drugs or toxin exposure, family history of polydipsia, and history of trauma or surgery. And in physical examination, looks for visual field examination, suggestive neoplasia, hypophysitis, or pituitary apoplexy, and skin, joint, lymph node examination, looking for systemic disease. Now, but coming back to our first case, when we take detailed history, what she is in fact suffering from is mouth dryness, which mandates that she is requiring almost 3 liters per day. However, she does not feel thirsty, and no nocturia, and no drinking at night. And she was able to fast Ramadan without an issue. And therefore, we did not really proceed with 24-hour urine collection. It was a bit difficult for her to do. And even you can, with this only history, be satisfied that this is not suggestive of polydipsia. However, sometimes you need to do labs to reassure yourself and reassure the patient. Since she has no nocturia, she is not waking up at night to drink, then you can just request morning fasting labs. And her morning fasting labs came out showing normal sodium, normal serum osmolarity, and normal urine osmolarity. And therefore, this patient has no diabetes insipidus and no need for any further testing. And in fact, over-the-counter weight loss medication that she was taking is contaminated with sibutramine, which is known to cause mouth dryness. Let's move to the second case. This is a 35-year-old female who came to the clinic post-discharge for transsphenoidal surgery for non-functioning pituitary adenoma 10 days prior. She is complaining from thirsty, polyuria, polydipsia. However, she cannot count how much she drinks. And she just informed you that she did labs in the morning. She did lab in the morning, but this was post-night desmopressin. And therefore, her labs basically are reassuring, where urine osmolarity is 677. However, the labs at the time of symptoms is highly going with DI, where serum osmolarity is 324 and urine osmolarity is 84. And you can see that most patients with DI have intact thirst sensation and therefore have normal sodium level. You could argue there's no need to do this for this patient, and I do agree. However, I'm just showing this to you for clarification. And therefore, from only history and very simple labs, this patient has central DI and no need for any further testing or stimulation test or confirmatory testing. So from these two cases, I'm showing to you that you need just to confirm the polyuria, take very detailed, clear history, and you may do basal testing if needed, however, in the right context, to ascertain the diagnosis. However, sometimes you may need something else. And then we'll move to the third case. So the third case is a 36-year-old female who had transsphenoidal surgery for tuberculous meningioma 6 months back. This actually was discovered during third trimester. She reported drinking lots of water, around 5 liters, and this is same during pregnancy. She could not fast Arafat day, wake up at night for drinking. She is seeking cold water, and she has polyuria. And her random labs showed normal sodium, serum osmolarity of 294, and low urine osmolarity. So with these symptoms and these labs, it's highly suggestive that this patient could have DI. Well, let's talk more about this. So plasma sodium, sometimes there's a huge overlap between primary polydipsia and central diabetes insipidus. And this is because patients with central diabetes insipidus, most of them, they will have thirst intact thirst sensation, and therefore they will have normal sodium level. However, sometimes, in fact, sodium can help you to differentiate between these two. Going through this pathway, if you confirm that the patient have hypotonic polyuria, that means they have polyuria confirmed above 50 ml per kg per 24 hours, and the urine osmolarity is hypotonic, not concentrated, and then plasma osmolarity was checked and it was high, above the upper normal limit, which is above 147, this confirms that the patient have DI, whether it is central or nephrogenic. However, if the serum sodium is below 135, this goes with primary polydipsia. So you need just to do basal testing in the right context, and you can differentiate between these two. However, many patients will have serum sodium within normal range, like our patient, and you are not clear whether this is really DI or not, and you need further testing to distinguish between DI and the primary polydipsia. And in these cases, you need further stimulation testing. And stimulation can be done through osmotic or non-osmotic stimuli. One of the major or well-known stimulating tests are water deprivation tests. Water deprivation test is basically two steps, a pre-DDEVP and post-DEVP. So the patient will go through fasting state or fasting phase, and then you will assess their urine osmolarity. If they were able to concentrate urine, then this goes with primary polydipsia. If it is the urine osmolarity was not inability to concentrate urine, then we'll go to the next step, which is desmopressin test. After desmopressin, if there was more than 50% increase in urine osmolarity, this is suggestive of complete central DI. If it is less than 50% increase in urine osmolarity, this is suggestive of nephrogenic DI. If the urine osmolarity after the fasting stage was around 300 to 800, then post-DDEVP, if the increase was more than 9%, this will go with primary polydipsia. If it is less than 9% increase in urine osmolarity, will go with partial central DI. So you can see here that the stimulation, osmotic stimulation here is thirst, and we are assessing the AFP concentration indirectly through the urinary concentration activity. So in our patient, she had water deprivation test, and in the pre-DDEVP first part of the test, during which is the fasting part, you can see that there was no reduction in urine volume. And also there was no increase in urine osmolarity, so inability to concentrate urine. While after giving her the DDEVP, there was a drop in urine volume and there was increase in urine osmolarity. And this is in the second part. So this is suggestive of central DI. However, there are lots of limitations and inaccuracy with water deprivation test. First, you need to know that the criteria of this test are based only on 36 patients. And the cutoff points that define the possible diagnosis post-desmopressin are in fact post-hoc analysis, and it's never been prospectively validated. In fact, the accuracy of this test have been evaluated only recently. Also, there is a lot of overlap with the water deprivation test. A primary polydipsia can impair concentrating ability of the kidney. Central DI can give increased AFP sensitivity. Partial nephrogenic DI can sometimes have AFP response. And therefore, this overlap can lead to inaccuracy in interpretation. Overall, the diagnostic accuracy of water deprivation test only 70%. And it is a long test duration, around 17 hours. And water deprivation test itself is not that strong stimuli. Therefore, there is a need for other testing. And the first idea came to just measure the plasma AFP. But this did not go into clinical practice because of several reasons. First, the AFP measurement have a high pre-analytic instability, technically very difficult. And the reliable assays that measure the AFP are not available commercially. And in fact, there are better alternatives. And the better alternative is called copeptin, which is a very good surrogate marker of AFP. It is secreted in a molar ratio with vasopressin. It can be measured through a very good assays that are available commercially, including immunoassay and immunofluorescent assays. It requires minimal amount of blood, and it is stable at room temperature for 7 days, and the results are available within 1 to 2 hours. So the first step, we need to find if the copeptin is correlating well with the plasma osmolality, and if it's correlating also with the AFP. And in these two studies, it showed that, in fact, the copeptine correlate better with the plasma osmolality, even better than AFP. And the correlation between the plasma AFP and the plasma copeptine is very high, 0.94. So this makes it a good surrogate and good marker to replace AFP. So the next step was to measure copeptine in patients with polydipsia, polyuria syndrome to differentiate between the different types. However, in this study, the stimuli they used is the water deprivation test. And therefore, with the baseline copeptine before stimulation, baseline copeptine below 2.6 was able to differentiate between complete central diabetes insipidus and the primary polydipsia, but not partial central diabetes insipidus. And with stimulation, the diagnostic test of copeptine with stimulation with water deprivation test was only 72%. So maybe this was suggestive that water deprivation test is not that strong stimuli. So the next step they moved to is to use copeptine again. However, they used a better stimulation where they combined both water deprivation test with a hypertonic saline, 3% saline. At baseline copeptine before stimulation, a level of copeptine of 21.4 picomole per liter was able to differentiate nephrogenic diabetes insipidus from the other different types of polyuria polydipsia syndrome. And with stimulation, a stimulated level of copeptine of 4.9 picomole per liter was highly accurate to differentiate between primary polydipsia and central diabetes insipidus, whether it is partial or complete. And this diagnostic accuracy of this was around 96%. To take this further, the same group went for an international multi-center prospective study that included around 156 patients. However, in this, they used each patient went through water deprivation test and hypertonic saline infusion test with measuring of copeptine level. They did not combine them together. And this is an aim to just have a better stimulation and less burden of testing. And this was the protocol for hypertonic saline infusion test, where the aim is to get the sodium level up to 147 and then to take the level of copeptine. And after that, you need to correct the hypernatremia. What this result showed is that hypertonic saline stimulated copeptine level above 4.9 cutoff was have high diagnostic accuracy to differentiate between primary polydipsia and central diabetes insipidus. And also, it has very high diagnostic accuracy to differentiate between primary polydipsia and partial diabetes insipidus. But using copeptine with water deprivation test, it was showed similar result to the previous study, where the diagnostic accuracy was in 70, 76, and 73%. So this was one of the first study that showed that copeptine level based stimulation is with only hypertonic saline was very accurate in differentiating between primary polydipsia and central diabetes insipidus, whether it is complete or partial. However, there was associated adverse events with this test. More patients with hypertonic saline infusion experienced symptoms of vertigo, headache, nausea, and malaise. And in fact, many patients, including 12 patients in the hypertonic saline infusion test, developed sodium level increased more than 155. And therefore, this test has some adverse effects that we have to count for. However, despite the adverse effects, the patient preferred hypertonic saline infusion over the water deprivation test. And maybe this is related to the duration of the test. So hypertonic saline infusion around average 3 hours, while water deprivation around 17 hours. So it makes a difference. So the summary from this study showed that the measurement of hypertonic saline stimulated copeptine is superior to indirect water deprivation test in distinguishing polyuria due to primary polydipsia from polyuria due to central diabetes insipidus. And however, the caveat is that more adverse effects are associated with hypertonic saline infusion. And hypertonic saline infusion requires close monitoring of sodium level to ensure the increase of plasma level into the hyperosmotic range while preventing osmotic overstimulation. And therefore, in setting where regular and rapid sodium monitoring is not possible, the hypertonic saline test should not be performed. So the same group tried to look for another way of stimulation, which is simpler and more safer. And they came up with arginine stimulation copeptin measurement. And this is a non-osmotic stimulation where they infuse arginine and they measure copeptin at baseline and 30, 45, 60, 90, and 120 minutes after the start of the arginine infusion. And you could see from this graph how it can differentiate between the different types of of polyuria polydipsia syndrome. And in fact, they found that the stimulated copeptin cutoff of 3.8 picomole at 30 minutes was the best to discriminate between diabetes insipidus and the primary polydipsia with accuracy of around 93%. And looking to the adverse events and trying retrospectively to compare to the hypertonic saline, of course, there is no issue of hypernatremia with the arginine stimulation. It still has the adverse effects of nausea, like hypertonic saline. However, the other adverse effects are less common with arginine, like vomiting, headache, or vertigo. And therefore, overall, the burden of this test compared to the hypertonic saline looks much better or less. And therefore, tolerability profile could be better with arginine stimulation, which make it more attractive. However, we need head-to-head comparison between these two tests, which is already a study is going on. This was the arginine stimulation test that was used in this study. And therefore, the summary of this study is that the arginine infusion is a potent stimuli and measurement of arginine-stimulated copeptin discriminate between patients with central DI from those patients with primary polydipsia. It is simple, novel, and safe. However, we need prospective head-to-head evaluation comparing both arginine stimulation and hypertonic saline infusion test, which is currently being performed. So only from this study, they suggested this algorithm that we measure baseline copeptin. If it is above 21.4, then this goes with nephrogenic diabetes insipidus. If it is below, then we do stimulation with arginine. And if the stimulated copeptin is above 3.8, this is primary polydipsia. If it is below 3.8 picomole per liter, this is complete or partial central DI. In case unclear cases, then we go with hypertonic saline infusion using the cutoff 4.9, since the diagnostic accuracy of hypertonic saline is slightly higher than the arginine stimulation test. And putting everything together, this is the proposed algorithm, where you have a patient with documented low urine osmolarity with polyuria, that's mean hypotonic polyuria polydipsia. If the plasma sodium is low, this goes with primary polydipsia. If the plasma sodium is above 147, this is then suggestive of DI. To differentiate between the two types, whether it is central or nephrogenic, you just measure random copeptin. If it is above 21.4, this is nephrogenic. If it is below 4.9, this is central. In case the situation in between, then again of sodium level, then you measure the random copeptin and you go on the same algorithm. If the copeptin below 21.4, you do arginine. If it's still unclear, then you go for hypertonic saline stimulation test. And this is in fact copeptin-based testing is replacing the water deprivation test in many centers around the world, where water deprivation test is becoming an obsolete. Now we move to the next part of the talk, which is management of central DI. Now, the principle of management of a chronic central DI is basically to replace the free water deficit with the appropriate fluid intake and replace the deficient hormone, which is the AFP, with its synthetic analog therapy, DDEJJ. And you treat the underlying condition and monitor of therapy and surveillance of the underlying causative disorder. Now, for the fluid management, since majority of patients will have intact thirst sensation, it makes it easy because osmotically stimulated thirst is normal in DI, then water intake in response to elevation plasma sodium concentration is appropriate. And therefore, this explains why most patients who present with a newly diagnosed DI have normal plasma sodium concentration. However, these patients sometimes, they may have hypernatremia, rarely. And this is if they cannot access water, like in fasting state or perioperative state, or if they have vomiting illness. Bear in mind, I'm talking only about a chronic central DI with a preserved thirst sensation. I'm not talking about adipsic DI. So the next step is to replace the missing hormones. And this graph shows you the slight changes in the naive AFP to produce the analog form, which is used pharmacologically. So the amino group of the cysteine has been removed in order to prolong the half-life to 6 to 8 hours, allowing 2 to 3 times administration. The L-arginine has been replaced with D-arginine, and this basically to effectively eliminate the pressor activity of the vasopressin. And therefore, the DDEVP has an antidiuretic to a vasopressor ratio of approximately 3,000. So it mostly acts as antidiuretic, not as a vasopressor. These are the commonly available DDEVP preparations, the intravenous subcut injections in 1 to 4 microgram, used mostly in patients who are unable to take orally or unconscious. The intranasal spray, the oral tablets, and the sublingual melt. The pharmacokinetics is slightly different between these forms. For example, the oral DDEVP comes at a doses of 100, 200, 400. It peaks within 2 hours. It is antidiuretic action lasts around 6 hours. It's affected by food, so preferably to be taken fasting. There is a sublingual form of it, which is much easier to take. Nasal DDEVP comes in a metered dose spray or via renal tube. It has a quick onset of action. However, the duration effect is variable. Effectiveness of nasal DDEVP is reduced by nasal mucosal inflammation or congestion or scarring, and therefore it is impractical to be used after transperineal surgery. The parenteral form that can be used in patients who are unable to take orally or unconscious comes in 1 to 4 microgram. The duration is proportional to the administered dose. And this is very important to know. The intravenous vasopressin is the original naive one. It has the vasopressor effect. It has short-term control of aqueresis in the intensive care unit. It is short half-life, makes therapeutic use for the naive hormone impractical. However, at supraphysiological concentration, it can activate the V1 receptor and the vascular smooth muscle cells, and therefore cause vasoconstriction. And therefore, it can be used to manage severe hypotension associated with circulatory shock. Now, one important thing to know about the desmopressin use in DI patient is that sometimes it can be associated with dysnatremia, where the patient can have both hyponatremia or hypernatremia. And this is one of the studies that retrospectively evaluated the patient who are on desmopressin and counting the number of dysnatremia that they had as outpatient or when they are admitted, whether in non-neurosurgical or in neurosurgical inpatient admission. And you can see that hyponatremia is quite common even in outpatient, around 14.6%. However, when the patients are admitted in non-neurosurgical admission, up to 74%. And in a neurosurgical inpatient, around a third of patient. With hypernatremia, also, it is mostly common in patient as inpatient rather than outpatient. And this is something very important to know, as we will address later. Also, when they try to look for the event of the incidence of dysnatremia based on the type of the central DI, it's mostly common with the adipsic DI, though still it's common with the patient, can happen with the patient with the intact thirst sensation. Adipsic DI patients are very prone to hypernatremia in around 50% of inpatient and outpatient around 20%. Other studies also try to look at this hyponatremia or dysnatremia is related to the types or routes of administration of desmopressin. And one of the studies showed that majority of patients who are on nasal spray DDEVP, 46 of them developed hyponatremia and around 14% had severe hyponatremia. Another study from Japan switched from nasal DDEVP to oral formulation. 33% developed hyponatremia in 4 weeks. However, another study found that switching the patient from intranasal to sublingual leads to 56% reduction in the risk of hyponatremia. In contrast, a Danish National Prescription Registry showed that hyponatremia that required related admission was only 1%. However, in this registry, almost 50% of the patients took only nocturnal DDEPP, and 10% only took DDEPP on demand. And this suggests that the majority of these patients were having actually partial DI. So from overall of this study, we can assume that patients who are taking only nocturnal DDEPP or requiring minimal amount, and patients who are using the oral form may be at a slightly lower risk of dysnatremia or hyponatremia with desmopressin. So how to avoid or to tackle this problem? The ways is to allow regular periods of free water clearance. And there are 3 ways to allow periods of water clearance. One way is to delay a dose of DDEPP once or twice per week to allow apheresis to occur, or to delay each tablet of DDEPP until a slight apheresis is evident. And this method actually is very effective, but it's very effective, but not every patient will like it. However, this is a very effective way. The other or the third way is to omit the tablets once a week, in a weekend, for example, to allow apheresis to happen, significant polyuria. However, this is not a method that's attractive and usually reserved for patients with recurrent hyponatremia who failed the previous 2 strategies. Another important point that I want to highlight is DI with intercurrent illness. And this is something very important to know, because there is a risk of severe harm or death when desmopressin is omitted or delayed in central diabetes insipidus patients when they are admitted. And therefore, it's very important to identify all patients with central diabetes insipidus on admission to the hospital and automatically consult endocrine service. There have to be careful pre-operative planning, including fluid and DDEPP prescription. And there have to be maybe dedicated prescribing alert system for all patients to prescribe DDEPP to reduce prescribing errors. And I direct the audience to go through this freely available clinical guidance from Society for Endocrinology regarding the inpatient management of cranial diabetes insipidus. So we came to the conclusion. DI is a rare disease. However, polyuria, polydipsia are common. We need to know the etiology, exact etiology, because treatment differs across the etiologies. Many times you need only basal testing. You will need stimulated test only if needed. Copeptine-based tests are the current stimulation test. Water deprivation will be a history. Water deficit replacement and DDEPP are the treatment options. And be aware of dysnatremia in patients using DDEPP and how to prevent this. Thank you for your listening, and we already reached the end of the presentation. Thank you.
Thank you, Raya, for the very interesting presentation. Before we move on to the 3rd presentation, I'd just like to remind the audience, if you have any questions, kindly post it in the Q&A box, and it will be answered toward the 3rd talk. And to remind our participants for tonight, we almost have 300 participants. This activity is CME accredited by Dubai Health Authority. You should be receiving your credits within 10 days. So we'll move on with the 3rd talk. The 3rd talk by Mr. Bakhit Bishtawi, how to get published in Dubai Diabetes and Endocrine Journal. Mr. Bakhit is a specialist librarian in Medical Library of Dubai Health Authority. His team is responsible for managing and developing all the library electronic collections, service, and training. He's as well editorial administrator, editorial office at Dubai Medical Journal. So without any further delay, I hand you the mic, Mr. Bakhit.
Thank you for the introduction. Let me share first my screen. Thank you for all for joining. How to get published in Dubai Diabetes and Endocrinology Journal, DDE. Here is the website of the journal and the electronic ISSN for this journal. My name, as you can see, and this is my email. Here is a picture of the Dubai Diabetes and Endocrinology Journal, and here is the covering page of the Dubai Medical Journal. Both these two journals are owned by Dubai Health Authority. Hopefully, the learning objectives of this session, by the end of this session, hopefully you will be able to analyze and integrate your research finding into a manuscript ready for publication, to define the author, the co-author, correspondence author roles, or another way, the authorship, and to understand the research ethical requirements, which is very important, by the way, and to communicate effectively with editors and peer reviewers to understand the journal's publication process, as well to avoid some or any scientific and publication misconduct. To introduce to you the DDE, formerly it was the International Journal of Diabetes and Metabolism. The name changed in 2020. So we are around 2 years with the new name, published quarterly by Dubai Health Authority and for Dubai Health Authority by Kargar, a well-known medical and scientific publisher, founder by Professor Youssef Al-Pastaki. The journal is peer-reviewed, double-blinded, open access, and no publication fees. We have our statistician to blind check your paper or your manuscript, and also we apply checking for plagiarism as well for similarity. The journal has, beside the ISSN, the DOI numbers, which is very important, and it's already listed in Google Scholar, DOIG, and we are heading to PubMed as well as Web of Science. We have our database of reviewers, which is updated frequently. The publisher, Kargar, Switzerland, based in Switzerland, and with more than 105 journals, many books covering the human medicine. The publisher also belongs to the COPE Ethics Committee, which is very important for journals and publishers. The Dubai Diabetes, we are, as Dubai, we are international, but we focus on UAE as well. The editorial board, we are adhering and going with the code of the best practice of COPE, the committee, and we have the editorial board assigned by Dubai Health Authority. This is very important. Editor-in-chief, we have the section editors and statistician. The editorial office in DHA, in the Medical Education and Research Department. Here is the list of the editorial board names. And by the way, it's very important whenever you want to publish to see the names of the editorial board. This makes a big difference to decide to go to that journal or not. For authors, we have the author guidelines. You can find it easily on the website of the journal. There is a manuscript submission manager system that manage all process from A to Z. Nothing is going via email. This is very important. Authors can track the manuscript status. Again, no publication fees and the system control to avoid operation delay as well. Whenever the manuscript is accepted, it will go for first published online. Here is a screenshot of the website of the journal. You can see here the journal home. You can read about the journal. Here, the most important part for you as an author, the guidelines. And when you are ready, you want to submit, go to submit the manuscript, create your account, and move. The minute you want to upload your manuscript, you should be ready with a title page, a manuscript, tables, figures, an accompanied letter, supplementary materials, and the submission statement. All these files should be separate. The title page should be separate from the manuscript, tables alone, figures alone, and so on. The good thing with the manuscript manager, there is instruction step by step. The system will ask you what to upload one after another. Here is the research article guideline template, and this is an example of a title page you need to prepare. In the title page, which will go blinded for reviewers, the title, the authors, the affiliation, the short title, correspondence author, address, and the keywords. The good thing with the journal, you can easily download the template and fill in that template. It's a Microsoft Office Word document. On the right here, you can see an example of a title page. Remember the A, B, C, or sometimes 1, 2, 3 reflect the affiliation, not the sorting of the authors, first author, something like this. So keep this in mind. And the affiliation should be the department or section, the institute or university or hospital, city, state, if there is a state, and country. It is as simple as like this. Make a short title of your long title, then fill in here the correspondence author details. And by the way, in the names of the authors, no need to add the titles, Mr., Mrs., Dr., Profs, all these are not added to the authors here, but in the correspondence author, you can write your title. Then how many tables you have, how many figures you have, and provide 3 to 5 keywords. Here is the template for the manuscript body. As any research, any manuscript, the components, the major components, which we usually check before your manuscript will be assigned to the editor-in-chief and to the editorial board, we are looking at the components, the abstract, the introduction, the methods, results, discussion, conclusion, statements, and references. If you have anything, for example, procedures or data analysis, you can put it as a subheading under these major headings. Here on the right side, the statements are differentiated, or you can see in the statement acknowledgement, the statement of ethics, the disclosure statement, the funding source, and author contributions. And lately, we added the data availability. This is another important part, and the references, which will be numerical according to Vancouver style. After you create your account as a new account, as a correspondence author, by the way, if you are 5 authors, one of you to act as a correspondence author only, and that author will communicate with the journal, okay? And the author, the correspondence author, will be responsible for all the communication, revision, and all the emails sent from the journal, editors, reviewers, to you as correspondence author. To start, create a new account, okay? And the new account, you will see yourself that you become an author and you can start a new submission. When you start a new submission, the system will guide you step by step what to do, from the guideline to authors, details, keywords, documents, reviewers, letter, send, okay? In the submission guideline, you need to confirm that you obey with the journal guideline. Then you continue to the author part. The system will ask you to add the authors. And here you can sort the authors as first author, last author, co-author. This is, you can easily find it in this area, because when you add the author, the system will ask you the role of this author, co-author, and then you will sort the arrangement of the order of the authors. Always remember to check and save and continue. For any reason, if you, for example, reach the keywords and you want to stop, you can save and leave the system and come back later to complete. This is very important, so as you will not lose what you did. Another important part, you will find it while you are submitting your manuscript, that to agree on the open access agreement. And for you, there is no eligibility to declare, because Dubai Authority will take care of all the open access fees on your behalf as an author. So you need to select that not eligible. To avoid junk and spam blocking emails, we usually advise you that to use your email like Yahoo, Gmail, or whatever. If you use your department, hospital, or whatever, it will work, but sometimes due to network restrictions, you might get the emails sent to the junk. But you can check from time to time the junk and the spam area for such emails. The type of articles you can submit, starting from the research articles, review articles, systematic review, meta-analysis, case reports, and to the end meeting reports and abstract. The good thing, every one of these type of articles, the journal will allow you to download a template, a Microsoft Office template, and that template is easy to fill and use. What not to publish? Out-of-dated works, previously published work in another journal. This is very important. I think not only with Dubai Diabetes and Endocrine Journal, but all journals, I think, are going on the same. Part of a book, conference proceedings, there is a debate. We will look on that. Manuscript submitted to another journal. You cannot submit the same manuscript to two journals. This is very important for you as an author. When you finish from the journal, you can go and submit to another. Audit relevant to a hospital, and this is because the audit has no ethical approval. That's why. Reports with no scientific value, big reports or monographs, master or doctorate thesis. Also, we will look at this part if we will accept for you to submit or not. Why to publish a research? I think ideally to contribute to science. This is very important, but practically maybe to get promoted, to get a job, to keep a job, to get funding, personal objectives, gain respect and admiration. And this is, by the way, important for you. Where to go, which journal you want to submit for example, if you want to get promoted. What are the requirements in your department for such promotion? The publication process in DDEJ the author submit the manuscript, the editorial office will check all the components. Then if it is ready, it will be sent to the editor-in-chief. The editor-in-chief will look at, then if it is okay, the editor-in-chief assign it to a section editor, and the section editor will look at the manuscript. Again, if they found it relevant, then they will send it to external reviewers. And if it is accepted, we will send it to the production team with the publisher, Kargar, and at the end, it will be published and the user can benefit from. The good thing, all these is managed via system, and it's a work flow. Remember, a good manuscript has good content and good presentation, both together. And for good content, it should be original, thorough literature review, and proper scientific methodology. A conclusion support the results. I saw some authors use the conclusion from other published papers. No, the conclusion is yours and it should be supported from your results. If you want to use the conclusion from other research, put it in the discussion part. Good presentation, clear, logically constructed, following the journal house style, simple English. So for this part, easily download the template of the journal and follow the instructions. Keep in mind, when you submit your manuscript, submit to only one journal. Check the language before submitting. Pay attention to the journal requirements, the guideline, and before you start the submission, prepare all the required documents and make them ready. Each file should be in a separate, each part should be in a separate file. For language, by the way, you can approach colleagues, or maybe you can approach an editing center to help in the language sometimes. Two important parts, the scientific misconduct and the publication misconduct. You need to keep an eye on both. The first one, falsification and fabrication, changing or adding results, you need 100% to avoid. And for the publication misconduct, plagiarism, high similarity, not following the journal guideline, multiple submission is not allowed for the same journal, duplicate sub-publication is not allowed, lack of references, inappropriate identification of all co-authors. All the authors, you need to define their roles. Ghost writing is not allowed, and conflict of interest, you should be transparent and show any conflict of interest. Okay, hiding conflict of interest is not good at all. Be transparent and show any COI. The manuscript status in Dubai Diabetes and Endocrine Journal is rejected before review, rejected after review, major revision, minor revision, and accepted. There is one status which usually we don't count, suspend. That suspend is before we accept your manuscript to go into the review process. So if you receive at the beginning something named suspend or suspicion or something like that, it means that the components of your manuscript are not completed. The ethical approval is missing. The consent is not there. There is no references, something like this. But after the acceptance for peer review, these are the 5 status you will get. Minor or major, simply it means that you are in the publishing cycle, but not final, okay? And nearly, by the way, every manuscript requires revision. So if you receive minor or major, especially if you receive minor, it's normal. It's possible to get mad, don't act. This is very important. Keep your madness to yourself. Don't act. Don't write the email and reply. I am like, no. Okay. Accept all the comments positively. Okay. All these comments are coming from your peers, from colleagues in the profession. Okay. Because usually when the editor sends your paper to a reviewer means somebody on the same profession. So accept all comments positively. If you disagree, explain why. And there is a part in the manuscript manager where you can type all your comments, whether you agree or disagree, or you want to suggest, or you want any feedback. So explain. Discuss with colleagues and co-authors all the comments you received in the status of minor or major revision. Responding to reviewers, be diplomatic, okay? And put yourself as a reviewer, okay? Remember, criticism is an opportunity for you to revise your manuscript. It's not an insult. If invited to resubmit, okay, do everything comprehensively and address all the comments. Don't leave any comments or just skip. No, address everything. If further experiments are requested, so you need to do that completely. Stay professional. The reviewers are your peers and colleagues. Okay. What don't help? Reviewers don't like my work. Therefore, they are biased. The journal is 100% double-blinded. The authors, the reviewers don't know each other. So this sentence will not work because they don't know you. I know who the referee, I know who is the reviewer. This will not help at all. Do you know who I am? Again, this will not help. Cosmetic revisions will not help. When you make the revision, make it completely, address it, and put down all what's in your mind. Oh, reasons for rejection may include not fit with the journal objectives. Clearly speculative paper. This is very important, by the way. The paper should depend on experiment, on result, on questionnaire, on inadequate literature. The literature review is not comprehensive, is not done. Weak methodology, poor analysis, not well-rounded. When you read it, you feel that it's the beginning, the middle, poor language, not formatted for the journal. These might be some of the rejection why your paper is rejected. What happened, or what if your manuscript is rejected? Remember, don't take offense. Don't overreact. The criticism are there to enhance your paper. Don't give up. It's a chance to improve your writing, good experience to learn how the system works. Take the guidance. Take the comments, because when the editor-in-chief rejects your paper, the comments the editorial board received from the reviewers they will give it to you. So take the guidance and the comments and improve your manuscript, and you might consider submitting elsewhere. Keep trying. This is happened everywhere, so rejection is not the end. An important part, the authorship sequence. In Dubai Diabetes and Endocrine Journal, we have the first author, correspondence author, and co-authors. Avoid gift honorary authorship, authors who didn't contribute. Simply, you might put the name of your head of section. Okay, ghost authorship, usually named ghostwriter. Example, a medical writer who drafts an article on behalf of an author or company. You need to avoid such thing. For gift and honorary, if there is no contributed, you need to avoid. So if you want to let your head of section be part with the authorship sequence, so he or she should contribute. How to avoid issues in authorship, and this is, by the way, very important. Agree on authorship at the start of research, not when begins writing. Okay, any helpers later on to be just acknowledged. And here people make confusion between thank you and acknowledgement. There is a big difference. Thank you is not in this part. Acknowledgement means somebody helped in the research, helped in the manuscript, but does not meet the author criteria. So at that time, you should acknowledge that person. But you cannot say that I would like to thank you, the patient. I would like to thank you, the participant. I would like to thank you, for example, the department. No, here acknowledgement is different from thank you. Each author is required to declare her individual contribution to the article. And if the paper is accepted, there is a document to be signed from all authors. Roles for all authors should be described in the manuscript contribution. You should write down in short what everyone did. Here is the ICMGE recommendation for authorship. Okay, you can see it. You can click on the the link and read more. And by the way, the 4 parts should be there. Drafting the work or revising it only is not author. Okay, so the most important part: contribution, drafting, final approval, agreement, all together, author. Acknowledgement, for example, advisors, proofreaders, typists, reference librarian, financial support. So you can acknowledge the proofreader, but you cannot put the proofreader an author. You can put the proofreader as an author if that proofreader contributes. Ethical approval, another important part, which usually the editorial office take care of. Authors should report in their manuscripts clearly ethical approval, the consent, name of the approval committee, number and date. And by the way, here, some authors wrote the name of, for example, the university. No, the university, if the university has a committee in the name of the university, then the university committee, but administrative papers or letters also is not accepted in this part. If you receive a letter from the head of section to make the research, this is not an ethical approval. The ethical approval should come from an ethical committee. Okay, patient signed consent and data source if applicable. Ethical approval should be sought, okay, and required, by the way, to ensure the dignity, rights, safety, and well-being of all participants. Required when the research involves human participants and or their data. Many authors said this is a retrospective study, I just open records. No, you need ethical approval. Patients, visitors, staff, people identified as potential research participants, access to data, records, or even physical materials. Use of access premises, facilities involve those with lack capacity, includes sensitive topics, sexual, illegal, political, religious. Remember, ethical approval cannot be granted retrospectively. Thank you. I think I am on time. Here is the contact of the editor-in-chief, and here is the journal contact. Thank you for listening, and I'm willing to answer your question later.
Thank you very much, Mr. Bakhit, for the very informative presentation. So I would like now to invite the panelists to the Q&A session. Unfortunately, today, Dr. Raya will not be able to get into the Q&A session. So for any questions that is posted to her, we might ask the MCI to post it in the EDS website, and if she logged in, she can answer the questions. Okay. So let's start with the first question that is directed to Dr. Noura. Here, a colleague is asking about the side effects of growth hormone. You have already addressed it in your presentation. If you give a short answer to this question, and he's asking if in females, do you recommend delaying the puberty when treating short stature?
Sure.
Yes,
regarding the side effects, in general, growth hormone is safe. Side effects in children is not that much infrequent. Short-term side effects usually related to the injection site, allergies related to, for example, if orthopedic issues, slipped capital femoral epiphysis, worsening scoliosis, usually with already known bone deformities, possible gynecomastia, for example, abnormal glucose metabolism, as has been mentioned before. Long term, there is no specific things. There are studies confirming, yes, some abnormalities in thyroid function test and in glucose, as been mentioned, with insulin insensitivity, and beside the theoretical risk of cancer. But no studies till now prove any increasing risk in such patients. In adults, I noticed that the reported side effects more related to fluid retention, to myalgia and arthralgia more. Regarding the other half of the question, it is actually not a routine at all to add, to delay puberty in patients on growth hormone. It is used as an additive, and yes, there are many studies suggesting LH-RH plus the growth hormone showing much better results than using growth hormone itself. But it is not of a routine use, no.
Noura, is there any harm of delaying the puberty for like a year or two with such
Again, it is not really a routine to do so, but I will say it depends on the case itself. So it is more of an individual case. In case a patient already presented late, already in the mid of a puberty, no much time to proceed or to complete the issue of the growth with a poor predicted final height, I might consider doing this. In other patients, for example, started early at 6 or 8 years, definitely no, I'm not gonna start with him. So all it depends on the response, even initial response of the patient and the growth hormone, how he is clinically doing.
It's like a salvage therapy before he goes into full puberty in some cases. I have a question to Mr. Bakhit. This is a common problem. I have a problem with my paper getting rejected, not because of its content, only because of English, and this is not my first language. Any suggestion for a proofread companies with a reasonable price that I can approach?
Yeah, thank you for the question. Yeah, for the language, it's advised to approach an editing center. If she approach us in the library, we can advise her with well-known professional centers. One of them is with Karger. There is an editing center, and they can help in the language.
Okay, thanks, Mr. Bakhit. The other question is for Dr. Noura. As we know, we have a low IGF in malnutrition. So may I know if the growth hormone would be high or low in malnutrition as compared to IGF?
Yeah. Again, growth hormone level is irrelevant in such cases. Again, we don't depend at all on a growth hormone level. So please don't do a random growth hormone level. In cases of a stimulation growth hormone test, it is proven, yes, the obese, more BMI, having a less response. So it's been expected it will affect the results. But again, why you are doing growth hormone? Why you are asking about growth hormone level in such patient?
Okay.
Clinically, it is not helpful at all, yeah.
So no need for basal growth hormone, IGF is enough. Okay, the question that is directed to Mr. Bakhit, what would you advise for a beginner in publications to go for high impact or low impact journals?
I don't think there is a link between a beginner or between a beginner author and high impact or low impact. The most important part is the author should be assured that this journal is not a predatory journal, not a fake journal. The author should be aware of all these things. It might be high impact, low impact. I'm not sure of this part, but the most important is the journal itself.
The journal itself. That's very clear. There another question for Dr. Noura. Would you rely more on IGF binding protein 3 or growth hormone stimulation test in diagnosing growth hormone deficiency in case of a non-availability of the stimulation test in certain labs?
Again, diagnosis of growth hormone deficiency, it is more of a clinical. It is more of a clinical diagnosis. So in highly suspected patients, it is more important than in clinically irrelevant patient. So as a baseline, it will be helpful. In such cases, typically they will have a low IGF-1 and IGF binding protein. But again, the stimulation test has been used as a gold standard test for such patients. We do have from time to time, I will say, a patient's been diagnosed more of a clinical growth hormone deficiency. Those patients are not, they didn't do the growth hormone stimulation for whatever reason. But again, clinically is more important, and the labs is gonna confirm the diagnosis rather than depending on the lab itself.
Okay, so they shouldn't rely on single, it's clinical oxyology and lab. We'll go to the questions that are directed to Mr. Bakhit. Does the cover letter and the abstract, isn't it both same? Why they are putting it in journals as a different submissions?
Yeah, thank
cover
you.
letter and abstract.
Yeah, thank you for this question. Actually, the covering letter is not part of the manuscript components or the research. The covering letter is just a letter administrative that the author want to submit this manuscript to this journal, and the author should write in this covering letter, for example, an introduction about his or her research, and to confirm that this manuscript is not submitted to any other journal or published before or something like this. Simply, the covering letter is something administrative and that is not part of the manuscript component like the abstract at all.
It's basically to tell the journal why his paper is interesting, why it is significant, why does it fit that journal.
And the most important, to confirm that this manuscript not published before, not submitted to another journal.
Yeah, that's clear. Okay, what's the, Noura, this is a question for you. What's the maximum dose of growth hormone can be given?
In general, growth hormone dose, it depends on the diagnosis itself. So in cases of growth hormone, we are talking about growth hormone deficiency. Usually in pediatrics, the dose is 0.025 up to 0.035 milligram per kg per day.
And they're asking about the updates, long-acting growth hormone.
The long-acting is actually has been approved for adults, I believe, last year. I'm not sure if it's been available here in our country or not yet. Trials in pediatrics still ongoing on, although I heard or I saw it somewhere, it has been as well approved for one of the companies last month. So long-acting is a very promising thing because it's going to help a lot in compliance. We do suffer with many patients in compliance because it is a daily injection. So make it once a week. It's will be a huge advantage, especially for pediatrics, I will say.
Okay, yeah, because the compliance is really an issue for a daily injection. Noura, by the way, what's the earliest age in pediatric you start the growth hormone?
For growth hormone in general, there is no limit for age. All it depends on the condition when you are diagnosed. So again, if we are talking about growth hormone deficiency, whenever you have this highly suspected case, you start your investigations and you confirm the diagnosis, you can start the treatment. And this is usually after 2 years, simply because the first 2 years of growth is actually more of a nutritional. Except the cases we are saying about the neonate and early infancy who present with hypoglycemia. So yes, they might be started earlier. So in general speaking, there is no limit specific age for growth hormone deficiency to be started on growth hormone.
Okay. There is a question, but I already it has been answered in the presentation of Mr. Bakhit. What are the common reasons? What is the most common reason you're experienced for paper rejection?
Yeah, as I mentioned in the paper, number one, usually the scientific part, and there is other parts like the components are not completed, the ethical approval is not there, plagiarism, similarity, like this, yes.
Sometimes the clarity of the project itself, what's the goal of this study?
That's the methodology, correct, yes.
Another question for you, Mr. Bakhit. How long does the process of review take in Dubai Journal until the author gets feedback?
Okay, for this question, actually, many journals cannot answer, even those well-known journals, Lancet or maybe NEJM, for the period. They cannot put limit period, but they usually try to do all the needful to finish the process as soon as possible. Some manuscripts might be accepted in 2 months, some of them in 1 year, but I want to add a point. If a manuscript is accepted in 1 week, there is something wrong, okay? So usually you need to give time and for the reviewers, for the editorial board, going, coming, and again, to put a period of time, I think this is not easy to confirm it.
Okay. Another question to you, Mr. Bakhit. Does Dubai Journal needs ethical committee approval for case report?
Okay, for case reports, number one, we need a consent from the patient, written consent, not verbal. This is number one. Number two, the author should say that the author is understand and obey to the Helsinki Declaration regarding the human subjects. Number three, authors should aware that ethical approval is not needed by the policy and the procedures of the Dubai Research and Scientific Committee. So there is no need for ethical approval, but this is not decided by the author. It's decided by the policies and the guidelines from the committee. So the best ethical statement for a case report that the author is aware of Helsinki Declaration regarding ethics. Number two, the ethical approval is not needed according to the ethical committee policies and guidelines in, for example, UAE or DHA. And number three, the consent or a written consent signed by the author is taken from the patient, or, for example, if the patient is a minor, from their parents or from the first kin.
Thank you very much for the addressing the questions of the attendees. Sorry, we have a long list of questions, but we're running out of time. So we'll be moving to the fourth speaker. For the unaddressed questions, I will encourage the presenters to log in to the EDS website to answer the questions if they have time, kindly. So we'll be moving to Dr. Hassanin. Dr. Hassanin will give us a talk on sulfonylurea in the current practice of type 2 management, consensus from the GCC countries advisory board. Dr. Hassanin, he's a consultant endocrine at Dubai Hospital, and he's the Deputy Director of Postgraduate Diabetes Education at Cardiff University in UK, and he's also well known for being the chair of DAR International Alliance. Sorry for the delay, Dr. Hassanin, the floor is yours.
Assalamu alaikum. Thank you very much, Budur. It's a pleasure to be with you all, and I've enjoyed myself the meeting very much, all the presentations. I encourage everyone to publish at Dubai Diabetes Endocrine Journal. As one of the deputy editors, I trust that we'll do our best to accommodate your needs. Let me just share my screen, and here is my presentation. Let me just get the right screen. Okay, you can see my screen. Okay, I take it that you do see my screen. So
yes, it's clear, Dr. Hassanin.
Yeah, thank you very much, Budur. So we're moving now from the discussion on pituitary issues of growth hormone deficiency or polyuria and polydipsia to another cause of polyuria and polydipsia, which is type 2 diabetes. Now, obviously, when we try to treat type 2 diabetes, we have a plethora of options. Sulfonylureas have been with us for many years, and the question is, with all the new drugs that are available for us, what is the current role of sulfonylureas in modern therapy? Now, being the co-author of this important paper that was published recently, the lead author is my very good friend from Saudi Arabia, from Riyadh, Dr. Yusuf Saleh, and all the names are here, including from UAE, Dr. Fathi Al-Awadi and Dr. Juma Al-Kabi, as well as myself. And it's, as mentioned, it's a Gulf paper, so there is the colleagues from Kuwait, from Oman, and from Bahrain, as well as from UAE and Dubai. So I will address the paper in a clinical scenario. I'm not going to go through page by page of the paper, but the thoughts and the ideas in the paper, I will address them through clinical scenario. So I just want you to all imagine a very, very straightforward, simple case of a female of 38 years old, work as a teacher, and be previously diagnosed with type 2 diabetes 6 months ago. She has type 2 diabetes. She has about five brothers and sisters, and one of them has diabetes as well as her mother. She's on metformin 1 tablet daily. She's unable to take more because of side effects. Whenever she checks her blood glucose monitoring, it's ranging between 150 to 200, and her HbA1c is about 8.1. Her BMI is 26. She's not hypertensive. Her lipid levels are normal. She has a normal renal function with no microalbuminuria and no retinopathy and no other medical conditions. So Basically, this is a fit and healthy lady who up to a few months ago, this year, she got diagnosed with type 2 diabetes, got started on metformin, not able to take the full dose, only takes 1 tablet a day, and she's not well controlled, with no other comorbidities or complications. So I just want you to think with me, why do we treat type 2 diabetes? Well, the simple answer in my mind is 2 things. One is to get good quality of life through being free of symptoms and free of complications. Diabetes is a chronic condition, sometimes is very asymptomatic, and it's really important that we try to address the quality of life through good glycemic control that will help the patient to be free of symptoms, but also to avoid long-term complications that could be difficult. Complications of diabetes are multiple, from as simple as neuropathy to the more difficult problems of dialysis, kidney problems, cardiac problems, and of course, hospitalization, and in many cases, unfortunately, early death. However, what we know is that good glycemic control can reduce microvascular complications in yellow and to an extent macrovascular complications as well. There's a linear relationship between the concentration of HbA1c and complications. That is very, very clear also in type 1 diabetes. So regardless of the type of diabetes, all types of complications are very much related to low to high HbA1c. When you get to the HbA1c of 7 or below, you can see here very low rate of complications. So how well are we doing? And I'll share with you some of the data that were done in Dubai Health Authority. The co-authors are my colleagues in Dubai Hospital and Dubai Health Authority in general. This was published a couple of years ago, 2019, where we looked into glycemic control over a series of 5 years, from 2012 to 2016, in both primary care, secondary care, specialist centers. And as you can see, a sizable proportion, about at best 40% and at worst 35%, have an HbA1c below 7%. So this tells me that there is a good proportion, roughly about 64% of our patients in need for better control. Now, we're not alone. We're doing as good as many other centers. Here, the target is less than 6.5. So it's not 7 as we've looked into our data, but less than 6.5 was 31%. So probably if we move it to 7, we will be more or less similar to our data. And this is European countries with well-established, structured health programs that are there for many, many years. So in general, there is lack of achievement of target for many of our patients. And it's important that we try to get to target early. I want you to look into the difference between all of these important trials. When you achieve the good glycemic control at time of diagnosis, and that was the big difference between UKPDS and other studies. UKPDS was, I'm telling my age now, but I recall the presentation of the data in Barcelona, the European conference, where everybody was delighted with the data because it told us at the time that getting good glycemic control as early as possible would be very important for lots of complications for our patients. So going back to the case scenario. Now, I chose a teacher because a teacher by job, you think it's perhaps an easy job, but a teacher is standing up all the time for 4 or 5 lessons per day. So this is hectic physical job that this teacher is exerting. Also, sometimes teachers are not well paid. They're not necessarily all of with good insurance. So it's important to take all of this into account. Look into the case scenario. I'm dissecting what's on. So she's got type 2 diabetes recently, only this year, on metformin, HbA1c is raised, blood pressure, lipids are normal, renal function normal, no other complication, and BMI is only 26. So I would like you to go back to our Emirates Diabetes Society guidelines. And by the way, that was published in the Dubai Diabetes and Endocrine Journal. So another reason to log in to the journal and to see one of the most influential publications in the region, which is our type 2 diabetes guidelines. When nowadays you see any patient, you ask yourself the question. The first question is, does the person have cardiovascular disease or target organ damage or not? If they do, then they are very high risk and they need specific treatment. Is the person age above 50? And in our case, no. Is the duration of diabetes more than 10? And in our case, also no. So with all of this, you end up with that your patient is moderate to low risk. Why this is important? Because over the last 5 years or 6 years, 2015 was the MPEREC publication. We have seen fantastic data on the importance of specific therapy to reduce cardiovascular and renal outcomes. But I would like to draw your attention. All of these cardiovascular outcome trials included in baseline multiple therapy. And in some of them, it was over 50% sulfonylurea. The lowest was 29%. So overall, whether the study was GLP-1 receptor based or SGLT2 receptor based, or even the other studies, it's really important to remember that these were patients taking regular medication of every day, including sulfonylurea. So sulfonylurea gets the confidence of the investigators in many, many centers, and they are considered to be an important drug. Safety-wise of sulfonylurea for cardiovascular outcome was tested in an excellent trial, the Carolina trial. The Carolina trial was trying to test the outcome for long-term treatment with linagliptin versus belimepride, one of the modern sulfonylureas. And obviously, the theory in here was that instead of comparing to a placebo, let's compare it to a drug that perhaps hypoglycemia or the class of the drug itself will be different. And as you can see here, the Carolina trial proved to show that sulfonylureas are as good as a modern DP4 inhibitor such as linagliptin. So what does the ADA say about choosing a drug? We need to look into efficacy, hypo rate, weight, major side effects, and costs. Now, I'm doing this presentation on the behalf of Survey, which I'd love to thank them as they give me the opportunity to engage with all of you tonight. Now, what we know about sulfonylureas, what they say in ADA is that efficacy is high and cost is low. But they say that hypoglycemia is moderate and weight gain. Now, I'd like to draw your attention to important points. Our rationale for writing the paper is that we feel that the word sulfonylurea is not well descriptive. It's very generalized item. Sulfonylurea as a class of drug are plenty of drugs. Equally, GLP-1 receptor agonists. We have seen many cardiovascular outcome trials. Some of them are positive, some of them are neutral. So we cannot generalize specifically that the sulfonylurea available in this stage and widely used is glibenclamide. We do not use in our region glibenclamide frequently. We mostly use gliclazide MR and belimepride. And what I'm trying to say is not all hypoglycemia, not all sulfonylurea are the same. What do we say in our guidelines for moderate and low risk category? Of course, for high risk and very high risk, the choice would be an SGLT2 with evidence or a GLP-1 receptor with agonist. If the problem is more of heart failure or kidney, then it's an SGLT2. If the problem is more of atherosclerosis, then it's a GLP-1 with evidence. But in the absence of this, we say, look into the profile of the drug and the lifestyle and the profile of the patient in front of you. One of them is efficacy, another is risk of hypo, third is impact on weight, fourth is cost. Obviously, if the HbA1c is above 10, then we need to consider an injectable therapy, specifically insulin. So talking about efficacy and durability, when we look into the advanced study, which is a very important study published in New England Journal of Medicine 2008, we've seen a very good response. Patients with near the target HbA1c, they got nearly 1% reduction. Patients with high HbA1c, they get a very impressive 4.3% HbA1 receptor reduction. So what is this telling me? It is telling me that regardless of the level of HbA1c, many of the patients would be able to achieve the target. That's number one. Number two, I would like to remind you that we are talking here about a study that was of a long duration, multiple years. So durability is really quite important here in the study. A very important real-world trial published only last year. The lead author here is my good friend Kamlesh Kunti from Leicester. They looked into how soon do people get to target and how long do they stay within target. So the probability of having the HbA1c below 7% were their objectives. And as you can see in the graph, gliclazide is blue, gliclazide MR is blue, and sitagliptin is green. Sitagliptin is a very well-respected DP4 inhibitor. And clearly, you can see here the difference. The probability is much higher with the hazard ratio of 1.35. So 35% higher probability of getting the 8 patients HbA1c to target with gliclazide MR versus sitagliptin. Now you'll say that perhaps this is on the expense of lots and lots of hypoglycemia. Now this is a big study that included over 6,000 persons, 3,000 plus in each arm. And as you can see, there was no significant difference in hypoglycemic events. And another crucial point, severe hypoglycemia that worries people going to hospital or calling for emergency support. That was pretty rare. We are talking about 4 patients at maximum out of 3,000. So that is nearly 1 in 1,000 persons. So this is really important. This is patients here. This is really important to remember. Now, I led a trial which we looked into the MENA region of 1,800 persons, and we looked into the type of therapy that people were on. This is the baseline characteristics of the trial. And as you can see here, 44% of patients treated with type 2 diabetes in MENA region are on sulfonylurea. The majority of it being glimepiride and gliclazide MR or gliclazide. Very important point. When we looked into hypoglycemia in normal months, not in fasting, not in Ramadan, the rates of hypoglycemia on oral therapy with sulfonylurea is 2.6%, and without sulfonylurea is 2.1%. So clearly, this is the incidence of confirmed hypoglycemia, not severe hypoglycemia. So clearly, there is hardly any difference, and not only hardly any difference, hardly there is any concern about hypoglycemia. You will say that this is observational, so these are people who tolerated the drug, and that's correct. Every drug has a side effect. A GLP-1 receptor agonist will have side effects. We want to test how well people will be tolerating the drug. So if I'm a person very sensitive to sulfonylurea and get hypos, change the treatment, put me on a different drug. But what's important to know that for the person who tolerates the drug, their possibility of hypoglycemia is as low as this. Now, what happened in the trial when they were in a and this is the Ramadan trial. This is another trial that we did from many countries in Muslim world. We looked into 1,200 persons on gliclazide MR, either as monotherapy or as dual or triple therapy, and we looked into rates of confirmed hypoglycemia before Ramadan, during Ramadan, and after Ramadan. So let's look into normal months, pre-Ramadan. What is rates of hypoglycemia with gliclazide MR? 0.2%. What is the rate of severe hypoglycemia? 0%. So this is yet another confirmation of what we saw in the Darmina trial, that the rates of hypoglycemia are pretty low. The difference between one trial and the other, now we are looking specifically into the gliclazide MR, into the Ramadan trial. And then even putting the patient into the 14, 15 hours of fast with no food or drink or any types of calories, the severe hypoglycemia remains still 0, and the confirmed hypoglycemia was 1.6%. So to me, this is really, really very reassuring. Testing the person under these circumstances then and getting the rates of hypoglycemia as low as they are is a testimony that the rates of hypoglycemia are far much lower than expected. What about weight gain? Well, here is the weight gain in the different clinical trials using different types of therapy. Now, as I mentioned to you, advanced use gliclazide MR, and there was 0 weight gain. UKPDS, on the sulfonylurea arm, there was 1.7 kilograms weight gain. So we're not really talking about massive weight gain. Going into the Carolina trial, the latest cardiovascular outcome trial, lasting for several years, comparison with DP4 inhibitor linagliptin. So I want you to look into the red line and the blue line. So the blue line is linagliptin, and the red line is glimepiride. And as you can see here, there is hardly any weight gain. The only difference is the patients on DP4 inhibitor, blue line, they lost 1.5 kilograms, while in the glimepiride, they did not lose weight, but also they did not gain weight. So this is really quite important because, as I told you again, the ADA is comparing with glibenclamide, which they frequently use, and we do not frequently use. So this is really quite an important differentiating factor. So in conclusion, ladies and gentlemen, getting good glycemic control is essential to avoid diabetes-related complications and to make the patient free of symptoms and improve quality of life. Modern sulfonylurea has evidence of reduction of complications and or equal safety compared to some of the DP4 inhibitors. In the advanced study, we show a reduction of renal complications, which affected mortality. What ADA says about them? Highly efficacious, and that we've seen in many clinical trials. The higher the HbA1c, the higher the probability of more reduction in HbA1c as well. What about weight gain? It's minimal with glimepiride, and we have not seen weight gain with gliclazide MR in the advanced trial. What about rates of hypoglycemia? I've shown you plenty of trials, at least 2 recent trials, as well as the Kamlish-Kunti trial with comparison with sitagliptin, where there was no clinical significant difference between the two, and in the Darmina and the Ramadan trial, rates of hypoglycemia were very low. And finally, a very important point that I didn't want to discuss too much is cost is very low. Even when we are in the wealth of UAE, cost is an issue for many of our patients. And with this, I'd like to thank you for some of the photos of my beloved home city, Alexandria. Thank you all, and I look forward to any questions if you have.
Thank you very much, Dr. Hassanin, for the very informative, comprehensive, and interesting presentation. I think the Carolina trial have added great support and service to the diabetes care, where they have proven the benefit of the SUs in the management of patients. Now, I have personally a question that what about the older SUs and the cardiovascular safety? Because, you know, in third countries, they are still using the very old one as they are cheap.
Sure. Thank you very much, Dr. Badur. I'm sorry, I'm calling you Badur because we work together all the time.
It's fine,
Badur,
it's fine.
and,
definitely, it's fine, Dr. Hassanin.
Yeah. So, as the chair of the meeting, it's important to. So, your question is about the older generation, which is glibenclamide. Now, if you remember, glibenclamide is the sulfonylurea in the UK PDS. Now, the UK PDS had two publications. One, the first one looking into the outcome of the sulfonylurea and or the insulin, and this shown fantastic reduction for microvascular complications. The macrovascular complications benefit was there for the metformin. But then the legacy effect was published 10 years later, and it showed the reduction in also macrovascular complications, cardiovascular specifically complications. And that was the sulfonylurea and insulin arm. So even for glibenclamide, the safety is there, but the hypoglycemia is low. You've mentioned the Carolina trial, Badur, and I had the trouble to go through the supplementary publications of the methodology and the design of the trial. And indeed, they were pushing to get the maximum sulfonylurea dose when we wouldn't do it in normal clinical practice with someone who's well controlled, and yet again to push for the maximum dose. And that affected the rates of hypos. But from safety point of view, from cardiovascular safety point of view, you've seen the graph, the two lines overlapping all the time.
Yeah, okay. Thank you. Let's see the audience. Okay, what's the best SU?
Well, I would say, based on the studies that we've shown, that there was the rates of hypoglycemia in glimepiride were a bit higher than the rates of hypoglycemia in gliclazide MR. Do we have head-to-head trials? Yes, we do. It's called the GUIDE study. They looked into head-to-head comparison of hypoglycemia, and gliclazide MR was much lower. So from my point of view, the top would be gliclazide MR followed by glimepiride.
I see. Okay, Dr. Hassan, how would you address the belief that SU accelerates the beta cells loss?
Well, that's a very interesting point. We grew up having that concept. And actually, when you think about it, the beta cell function, now go through the trials of the durability, the trials such as Advance, trials even such as the Carolina. Go to the Carolina and look into the duration of diabetes of these patients. It was not at the time of diagnosis. And the trial itself was for 3 years. And nevertheless, they carried on. Now, the latest point of the durability is presented in the ADA called the GRADE study. The GRADE study is a WOW design looking into 4 different lines of therapy. And they were looking into what will be this best second line therapy. And they didn't see after 5 years, at the end of the trial, the durability of GLP-1 receptor agonists, insulin, sitagliptin, and glimepiride is almost identical between the 4. So the issue of the beta cell function going to be exhausted, 50% is lost at time of diagnosis. I think this was theoretical. the era of insulin resistance, and the clinical trials over the last 5 years prove that this might have been an exaggeration.
Thank you very much.
I'd like everyone to go and search for the great study. It's a very important trial. It opens so many points. And I would suggest for the Young Leaders Forum is to perhaps look into a review of the great study, because it tried to answer a very important question.
Well taken, Dr. Hassanin. The discussion with you is very interesting, but we are running, we are delayed by almost 30 minutes. So I would thank all the distinguished speakers. Thank you so much for the participation. I hope you enjoyed the academic activity, and thanks for the 300 attendees who stayed till late night with us today. Hope you enjoyed our academic activity. Thank you again for attending the Young Leader Forum. Just to remind you, our activity is CME accredited by Dubai Health Authority. You will be receiving an evaluation. Kindly fill the form within 10 to 14 days. You should be receiving your credits. Again, if you want to watch the webinar for today, you can get it on demand on the EDES Institute website or the EDES YouTube channel. Our upcoming next Young Leader Forum will be in December, 15 December, and our theme for that day will be endocrine disorders in women. And we are having the EDS Connect Diabetes and Retinopathy webinar on 2nd of November, the next month. The EDS Society have started thyroid webinars already. The first webinar have taken place. The upcoming one about hyperthyroidism will be in 29th of October. And you can see there are 6 webinars for thyroid course. And we'll be having our next EDIC Conference 2022 on 24th to 26th February 2022. So thank you for attendance again, and good night.